prosthetic hip or a knee. And most of these are methicillin resistant. They are that same methicillin resistance this MRSA has, and we often call these MRSE. So be aware, you can have methicillin resistance, and if it's a staph epi, who cares? It doesn't mean anything at all. Now, I think in your handout there may be a misprint here, but for the coagulase positive, all these are called Staphylococcus aureus, and these are the ones we're concerned about. They cause boils and abscesses, surgical wound infections, bloodstream infections. They live right in the interior of your nose, in the anterior areas, and that's their home. And then they temporarily can colonize the skin if you touch your nose and then touch your skin. But they really prefer right in the front of your nose. About 20 to 40% of everyone in this room would have Staph aureus if I cultured your nose. Up to 90% of healthcare workers will grow this from their nose. So then we switch to this methicillin resistance. What is that all about, the M and the R? Penicillin was very first used in 1941 in a policeman in Oxford, England, who had a skin infection. It was so rare at the time that what they would do is they'd actually collect the urine from the patient. They would crystallize the penicillin out of the urine of the patient, sterilize it, and give it back again. That's how rare penicillin was. First use was 1941. By 1944, we had already discovered this beta-lactamase that the bacteria probably had for 1 billion years, but now we were selecting these because they could survive penicillin. By 1947, 3/4 of every Staph aureus in the hospital was now one of these penicillin-resistant bacteria. We hadn't even known about them a few years earlier. Then by 1960, essentially all Staph aureus, whether in the hospital or the community now, were fully resistant to penicillin. So that's how quickly these antibiotics can these bacteria can overcome our antibiotics and become totally resistant. Usually resistance starts in the hospital and then comes out in the community. Right now, about 98% of all Staph aureus are penicillin resistant. And this is that beta-lactam ring right here. And so beta-lactamase is an enzyme that breaks that ring open and completely inactivates the penicillin so it doesn't work. So what we said is, well, we'll go one up on you. We'll create an antibiotic called methicillin. And this methicillin was completely resistant to that enzyme. So even if the bacteria had the beta-lactamase, methicillin could still kill it. Guess how long that lasted? 1 year. The next year, we found Staph aureus that were methicillin resistant. So they produced a mechanism of resistance that would break down and inactivate methicillin. Now, methicillin was a very toxic antibiotic, so it went out of use probably 25, 30 years ago. But we still kept that name, methicillin-resistant Staphylococcus aureus, even though you couldn't find methicillin in a hospital. In fact, on the sensitivity panels, we actually use oxycillin. We don't even use it to test in the lab. But that MRSA never caught on, and we still call it MRSA. So what this bug has done is even a little bit weirder. Penicillins work by binding to what's called a penicillin-binding protein, which all bacteria have. And what it decided to do was just mutate that enzyme. So it's now a little mutant, and penicillin won't bind to it, cephalosporins won't bind to it, and now it's fully resistant to all penicillins and all cephalosporins with one tiny little mutation, and it beat us. So the first one we saw then was hospital-acquired methicillin-resistant Staph aureus. It was first reported in '63. Remember, we only introduced methicillin in '60. We already had outbreaks in hospitals. Came to the United States in the mid-'60s, and we went from 2% to 29% to now over 60% of all Staph aureus in hospitals in the U.S. are MRSAs. Over 60% of all of them. Now, what happened in the fall that started to raise such a ruckus, in addition to the unfortunate student in Bedford, was this report in the Journal of the American Medical Association. And what they found in this was almost 9,000 MRSA infections, almost all of them healthcare acquired. 94,000 cases and 19,000 deaths due to MRSA every year. Physicians have known about this since the '60s. This was no surprise to us. But it all of a sudden caught the news, and people said, oh my goodness, this is MRSA, this is something new. It's 40 years ago we've been dealing with this. Now, if you take the methicillin-sensitive Staph aureus, which is the usual, and compare it to this MRSA, hospitalizations are 50% longer. You're 3 times more likely to die, and it's much more expensive. So this MRSA is bad news. Now, what do we use in the hospital? For 30 years, we've used a drug called vancomycin to overcome this methicillin resistance. Now, you have to know a little bit about vancomycin to understand this ditty. Vancomycin, when it first came out, was so impure it was brown. They actually called it Mississippi River mud. It was initially found from a fungus in the Amazon. So there is an antibiotic called mud that's proving to be quite a dud. Its provenance is jungle, its use is a bungle, it just won't get rid of your crud. So basically we are losing the power drug we've used for 30 years. People are talking about the Andromeda strain. We are already seeing Visa and Versa, that's not your credit card. This is vancomycin intermediate resistant Staph aureus and vancomycin fully resistant Staph aureus. And we are dealing with this now on a fairly regular basis in hospitals. So we're losing the next generation of antibiotic. And then all of a sudden, this guy came on the scene. Community-acquired methicillin-resistant Staph aureus, for CA MRSA, and this is really what you're going to be dealing with in the workplace almost exclusively. And this is what happened in Vector. So back to that article that came out in the fall in JAMA, you see the bottom line, 58% of these healthcare-associated infections, where they come from? They started in the community and got admitted to the hospital. So it was really a community-acquired MRSA. And it got blamed on the hospital. So now what we're seeing is this community-associated MRSA is actually becoming more common than the hospital-associated. Now what happened here is this is a totally different Staph aureus. It's a different clone. It's more virulent. It's more deadly. It's more invasive. It's more resistant to killing by white blood cells that protect you than the hospital variant. So it turns out this community-acquired actually is worse than the original hospital-acquired. And how did it get this virulence and this new resistance? It got a genetic transfer from Staph epidermidis, the one that lives on our skin that was already methicillin resistant, and it transferred its resistance package to Staph aureus. And now we have a totally new bug called community-acquired MRSA. So members of the Staphylococcus are getting together to share genetic information, widening the range of hosts that can be infected by its most aggressive species, which is Staph aureus. And what it produces is an enzyme called Panton-Valentine leukocyte, and we call it PVL. The important thing is if you purify that PVL and inject it into your skin, it'll kill the skin. So this is what causes that dermonecrotic lesion that is often mistaken for a brown recluse spider bite. It's this toxin, and the hospital-acquired variant doesn't have it. So this community-acquired that you can get in your own community is actually worse because it has this toxin. And this toxin is on a small mobile gene cassette. What I mean by mobile is it can go from bacteria to bacteria very, very easily. They just transfer this thing around like you put a cassette into a machine. It's good because it's a small mobile element, so there's not much resistance on it. So we have other options we don't have with the hospital-acquired, but it's bad because it's so easily transferred from bacteria to bacteria. Now, what are the risk factors for getting community-acquired MRSA? Overcrowded conditions, poor personal hygiene, any minor abrasion or skin laceration you can get, but even any minor abrasion, that's going to be the setup. It's growing in your nose. You have a small abrasion on your arm, say like a mat burn in a wrestler. You contaminate that abrasion, and the next thing you know, you've got an invasive MRSA infection. And of course, sharing contaminated items like they did in the jails, but it can be as simple as sharing towels or other items in the workplace. So what has happened is this community-acquired MRSA, which we didn't even know about 8 years ago, now has become a nationwide and worldwide epidemic of a new MRSA, the community-acquired MRSA. There have been outbreaks on sports teams. There was one in the LA Rams. I think you've seen some of the Washington Redskins have developed these severe community-acquired MRSA infections. There was an outbreak on the ODU wrestling team, outbreaks of homeless use with IV drug users, daycare centers, and military units. We've had outbreaks essentially everywhere, and long before last fall with the case in Bedford. So it's really just explosively increased. In my 25 years of infectious practice, I don't think I've ever seen a bug spread throughout the country this quickly. These things just spread like wildfire, and I think because of that whole transmissible gene. In fact, by 2006, almost 60% of all skin infections in the entire United States were caused by this organism. 60%. In fact, they tried to do this was a study of emergency rooms around the United States, and you can see that of skin infections in emergency rooms, 64% were community-acquired MRSA, and this was back in 2004. And on the Mid-Atlantic, you can see we have some of the highest rates in the hospital. In fact, they tried to do a study of methicillin-sensitive versus methicillin-resistant Staph aureus in Portsmouth Naval Hospital, and they couldn't do the study because 85% of all the skin infections they saw were MRSA, community-acquired MRSA, coming from the community. 85%. They just had to stop the study because there were so few of this sensitive. Another thing you need to understand is the difference between colonization and infection. Colonization is when the bacteria is just living in your nose or on your skin but not causing any disease. Of course, infection is when you go from colonization, then it invades you and it causes disease. So colonized patients usually do not need treatment because it's just living there. It's difficult to eradicate. We'll talk about that later. And infected patients actually cure their infection often will then become permanently colonized and at risk again of recurrence. So this was a large study looking in the United States, and what they found is about 32% of the U.S. population had Staph aureus, but less than 1% had the MRSA. So that looked like good news, but if you translate that, it's still about 2 million MRSA in the United States, people colonized with it, and about half of those are the bad community-acquired MRSA. It was found more common in younger, so this is a real problem in children. Pediatric emergency rooms, essentially every skin infection you see is going to be community-acquired MRSA. Unfortunately, what we've seen since that study is increasing levels of colonization with community-acquired MRSA in the United States. In Nashville, it was 90% were colonized with community-acquired MRSA. 7% of adults and adolescents in Atlanta. So we're now going from less than 1%. We're getting in the range of 5 to 7 to 8% of the entire population is now colonized with this community-acquired MRSA. And what we're seeing is these are bad infections. They're necrotizing infections, and what that means is it kills flesh. And it will kill muscle, it will kill lung, it causes necrotizing infections. Also, what we're seeing is complications of influenza. You used to get influenza, you get better. Now what we're seeing is fatal, complicating, community-acquired MRSA infections on top of the influenza. And each flu season, we're seeing more and more young, healthy people abruptly die of complicating community-acquired MRSA infection on top of their flu. If they didn't get it, they would have been alive. Just this year, it just came out last week, there are 51 cases of community-acquired MRSA complicating influenza reported. 24 of these died. They were an average age of about 16 years old, so they're usually young, and they died the 4th day of their pneumonia, on average. Yes?
Is this the same as the flesh-eating bacteria?
No. Good question. That's a group A streptococcus, is the flesh-eating bacteria. This one is not quite as bad as that one. That's the group A streptococcus. But this can do just about the same, but not quite as bad. We're also seeing outbreaks in newborns, which are often confused with herpes and other infections. And interestingly, now it looks like it may be a sexually transmitted disease. We're seeing transmission from one sex partner to the other, often people that did what? Shaved their pubic hair. And so you get minor abrasions when you shave the hair. You get an infection with MRSA, and you can transmit it to your sex partner. There was actually a recent report in the Annals of Emergency Medicine called the Lap Dancer's Lament. And it was a series of lap dancers who had community-acquired MRSA abscesses on their buttons. We're also seeing now community-acquired MRSA infections in dogs and our pets. And what's happening is we are giving the MRSA to our pets. And for the cats, surprisingly, they get urinary tract infections, community-acquired MRSA. The dogs often will get ear infections and abscesses. And the feeling is we're transmitting that to our pets. And now it's got a full cycle now. So actually, when you have MRSA in the hospital, it's not the old-fashioned hospital-acquired MRSA, it's this new worse community-acquired MRSA that people are getting infected. It's a severe infection, requires hospitalization, and then we culture the MRSA. Over half of MRSA now in the hospital is not the hospital MRSA, it's the community-acquired MRSA. So how do we treat this? Well, it turns out up until about, I'd say 3 years ago, if you went in with a skin infection or a boil, you probably would have gotten Keflex or dicloxacillin. And it turns out that all MRSA are resistant to both of those. So in those studies done in the emergency room, 83% of the times the physician gave the wrong antibiotic, one that it was fully resistant to. The real way you treat these is incision and drainage, or IND. So you either numb up the skin and you lance the boil, or you put heat on it, bring it to a head, and let it spontaneously boil. But without that drainage, the antibiotics don't do anything. Antibiotics alone for an abscess don't work. So incision and drainage is really the treatment for these infections. And this is from that study in the emergency room. And you can see they were using Keflex here, almost 57%. 100% are resistant to Keflex. 100% are resistant to antistaphylococcal penicillins like Diclox. So physicians got it totally wrong until about 1 or 2 years ago. We realized how incredibly common this was. And now what you're most likely to get is trimethoprim sulfamethoxazole called Septra or Bactrim. And you can see that almost all of them, there's no resistance to community-acquired MRSA. So we have a situation where the most common drugs used were completely ineffective against the most common pathogen, which was community-acquired MRSA. So incision and drainage alone is going to be adequate for most uncomplicated abscesses. But if you go and you have an abscess and you can feel it's fluctuant and kind of you know there's some pus under there, antibiotics aren't going to do anything. It's really not even going to start healing until it drains. So some people will do IND for the bigger ones and then they'll add an antibiotic to it, which is okay. The antibiotic alone, though, really doesn't do much until it drains. And probably it's a good idea now to start culturing these so we know what we're dealing with. In the past, you just say, oh, you got a skin infection, here's your Keflex. Now you can probably incision and drainage, maybe Bactrim or Septra, and culture the pus that comes out. And so these are the ones that you might be able to use for community-acquired MRSA. Clindamycin or Cleocin is an oral antibiotic. The Bactrim or Septra. The tetracyclines work very well against community-acquired MRSA. And rifampin is incredibly powerful, but you would always use it with another antibiotic. So usually for a severe infection, we'll add the rifampin. So you do, the only fortunate thing about community-acquired MRSA is we have options that are not particularly expensive. Unfortunately, once you get one infection, because you're colonizing your nose, you're set up for recurrences. So 30 to 45% of people are going to have recurrence at a new site. Yes?
You took the erythromycin or that
Yeah, that's a little bit, I would not use erythromycin at all for these. What happens is they have, if they're resistant to erythromycin, which is increasing, they can actually induce resistance to clindamycin. I would say probably half or more now erythromycin resistant, so I wouldn't even go there. The other problem with erythromycin is it binds to a receptor in your stomach called motilin and causes acute contraction of the stomach and nausea and vomiting and abdominal pain. And the younger you are, the more motilin receptors you have, the worse that side effects. So erythromycin is just a difficult drug to use, and it's 4 times a day. I would avoid it for community-acquired MRSA. So back to our recurrences. Interestingly, when you have an antibiotic that works or not, it doesn't interfere with that. It doesn't make any difference with recurrences. It's still about the same. About 1 in 3 people is going to come back with a site. And punishment? Probably because you're still colonized, and then the next time you get an abrasion, you accidentally inoculate it, and then you've got a recurrence. So this was from the Virginia pilot after that case in Bedford. So in October 2007, there was a senior student who died of community-acquired MRSA at Stanton River High School in Bedford County. About several hundred students actually then protested that they didn't even want to go back to the school. There was this huge panic. They refused to go to the school. The parents started coming in refusing to let the students go back to school until they demanded that the schools be cleaned. So to deal with this, the school system hired Servpro,